Good morning, ladies and gentlemen. Today is my third lecture on the same topic, that is the bacterial infections. So in this lecture, I'm again going to discuss a few bacterial infections. And unfortunately, I will not be able to complete this chapter even in today's lecture. So I will be requiring another lecture to complete this large chapter. So let's proceed for today's lecture. First of all, we are going to discuss the coroniform bacteria. The coroniform bacteria are the gram-positive, non-sporing, rod-shaped organisms, which are commonly referred to as diphtheroids. So this classification embraces Corynebacterium diphtheria, the cutaneous aerobic coroniform bacteria, then Corynebacterium and Bacterium species, as well as an important anaerobic Corynebacterium, which is called as the Propionibacterium, among which one of the bacteria is Propionibacterium acne, which is the main pathogen of acne vulgaris. And it is generally acceptable that the Trichomycosis axillaris and Erythrasmas are also caused by the resident coroniform bacteria in the skin. And so is the pitted keratolysis. We are going to discuss these diseases shortly. So diphtheria is mainly a disease of upper respiratory tract. It is caused by Corynebacterium diphtheria, and it is isolated from the nose and throat of healthy carriers who have recovered from the faucial diphtheria. The rate of infection is considerably less in individuals who have received the immunization. So diphtheria toxin consists of two fragments, a polypeptide, which is an active segment, and a B fragment, which bind to cell surface receptor. An important feature of this Corynebacterium diphtheria is its association with yaws, which is a spirochetal infection common in Pacific region. And cutaneous diphtheria is rarely reported in temperate climates. So this a toxigenic strain of Corynebacterium diphtheria causes this cutaneous diphtheria, which is a local necrotic change, and it typically characterized by a superficial, rounded, oval, or irregular linear ulcer with clearly defined and overhanging edges. Exudate from the ulcer floor tend to form a tough gray or brownish gray adherent membrane, like we see the membrane in the oral mucosa. There can be moderate enlargement of regional lymph nodes. In temperate climates, the lesions occur most commonly at the umbilicus, behind the ear, genitocrural fold, toe clefts, and develop in any pre-existing skin lesion. And this lesion persists for 6 to 12 weeks, heal with a scar formation. Sometimes systemic manifestations are seen, but are usually mild and absent. There may be neurological complaints or even myocarditis. The diagnosis is confirmed bacteriologically. The toxin production is detected by immunochromatographic strip assay. Treatment. A specific antitoxin should be administered as soon as the diagnosis is suspected. 20,000 to 50,000 units given intramuscular. And antibiotic of choice is penicillin or erythromycin. And erythromycin is probably the most effective compound for eradicating the skin carriage of these diphtheria. Then another Corynebacterium is Corynebacterium pyogenes, which is connected to outbreaks of skin ulceration. This bacteria is reclassified as Actinomyces pyogenes. The clinical appearance closely resembles that of pyoderma and tropical ulcers. The disease is spread by flies, and the bacteria causes skin necrosis, but the mechanism is not well established. Then a common infection is Erythrasma. Erythrasma is a mild chronic, localized, superficial infection of skin that is caused by a coroniform bacteria, usually the Corynebacterium minitismus. The organism responsible are frequent member of normal flora, and at least in the toe clefts. And there is some shift in host-parasite relationship, resulting in the development of the disease. A warm, humid climate or environment predisposed to this infection. Infection may occur at any age, but more common in adults than in children. The commonest presentation is a mild toe cleft scaling with pink fluorescence. Groin is less frequently involved, and axillae even lesser. Erythrasma affects mainly axilla, inframammary folds, groins, particularly in obese, and diabetes is a common association. The newer lesions are smooth, but older lesions tend to be finely creased or obviously scaled. The lesions are symptomless, but in tropics, irritation of the lesions in groin may lead to scratching and lichenification. Secondary infection of toe cleft may also occur. So this is how erythrasma look like. Well-localized scaly rash, bilaterally symmetrical on both axillae and even groin. And there is no active border and central clearing. And if we see under Wood's light, then it will give a pinkish red fluorescence. So this is a toe or toe cleft infection. It simulates the tinea pedis, but in tinea pedis there is no fluorescence. And if we do biopsy and a PAS stain, then these bacilli, these bacteria, they take up PAS and look like, although they are not separate hyphae, but they are rods, but they take up the PAS stain. Wood's light examination gives a coral red fluorescence. Pink fluorescence is also demonstrated in some necrotic tumor and on the normal tongue. So whenever in doubt, ask the patient to protrude the tongue to see what color you expect from the lesions in axilla or the groin. Acanthosis nigricans may fluorescence bright pink, presumably due to heavy colonization of Corynebacterium. Prognosis without treatment condition tend to persist indefinitely, although there may be spontaneous fluctuation in the severity of symptoms. DD includes pityriasis versicolor, but it is usually found on the trunk and not on the folds. Tinea crurus may simulate, but it is asymmetrical, and there is usually an active border and central clearance. The border will have vesiculation and satellite pustules or papules. Flexural psoriasis should be excluded. It is more beefy red and little indurated. Laboratory identification is scraping from the affected area show bacteria with fine filaments, and culture confirmation is not normally necessary, and Wood's lamp examination is usually sufficient a test to diagnose the disease. Treatment. Erythrasma respond very well to topically applied azole antifungal agents like clotrimazole and miconazole for 2 weeks. For extensive lesion, erythromycin is the oral antibiotic of choice, or can be given for 5 to 7 days, or a single dose of 1 gram of clarithromycin. Alternate include topical fusidine and oral tetracycline. Then long-term antiseptic soaps like povidone iodine and photodynamic therapy using the porphyrin produced by the causative organisms have been tried with some benefit. Trichomycosis axillaris. Trichomycosis axillaris is a superficial infection of axillary and pubic hairs with formation of adherent granular nodules, yellow, black, or red on the hair shaft. The cultural studies show a variety of different types of aerobic Corynebacteria to be involved, like Corynebacterium tennis. It is shown that the changes in chemical environment of these organisms may induce pigment production, which explain why there are different colors of the nodules. This is usually an asymptomatic condition, and the patient just notice the yellow, black, or red concretions on the hair shaft, which are hard or soft and nodular or diffuse. So these are the concretions which are related to the hairs. The axillary sweat may be yellow, black, or red according to the color of concretions, and clothing may be stained. The yellow type is the most common and black is the rarest. Sex difference is largely explained by absence of axillary hair in women, and pubic infection is less common. Pediculosis, pubis, and pydra should be considered in the DD. Examination under Wood's light is helpful because it again gave a fluorescence. Microscopic confirmation is desirable. QH mount shows the narrow vessely organisms with red or yellow concretions, and these are gram-positive organisms. Treatment is simply by cutting the hairs of axilla and pubic region and applying application of antimicrobial ointments like benzoic acid compound and 1% aqueous formalin. However, the use of effective antiperspirant such as anhydrous aluminum chloride is again a rapid mean of therapy because it is antiseptic and antiperspirant and deodorant as well. So another important disease caused by Corynebacterium is the pitted keratolysis. This is a skin condition which is caused by Corynebacterium, now labeled as Actinomyces keratolytica, Dermophilus congolensis, and Micrococcus sedentarius. And it is characterized by circular erosions on the sole. Histology, a mixture of coccoid bacteria and filamentous microorganisms are seen in abundance in most superficial part of stratum corneum and extending down between the keratinocytes. There is associated lysis of keratin. Clinically, it is characterized by numerous superficial erosions of the horny layer of sole and undersurface of the toes. Pressure bearing or friction areas are most commonly affected. Discrete, shallow, circular lesions with punched out appearance coalesce in place to produce irregular erosions. There is occasionally green or brown discoloration of the horny layer. Hyperhidrosis is often associated, sometimes with maceration, stickiness, and foul odor. Under battle conditions, soreness and pain is reported. Similar changes in palm is rarely reported. So this is how the small pinpoint erosions of pitted keratolysis look like. Treatment is first of hyperhidrosis, and the condition rapidly respond to fusidin ointment. Topical antibiotics like imidazole, such as clotrimazole, is also helpful. Botulinum toxin is useful in reducing hyperhidrosis and helping treating the disease. Propionibacterium. Propionibacterium are gram-positive anaerobic chroniform bacterium, which are the resident normal flora and is widely distributed in the whole skin. Mainly, there are 3 species: Propionibacteria acne, Propionibacterium granulosum, which are found mainly in pilosebaceous follicles, and Propionibacterium avidum, which is found in moist intratragenous areas. So Propionibacterium acne and granulosum have a key role in causation of acne. In addition to its association with acne, P. acne is isolated from endocarditis and meningitis associated with presence of ventriculo-lateral and ventriculo-arterial and ventriculo-peritoneal shunts. It is also a cause of indolent folliculitis. Anthrax. Anthrax is a zoonotic infection with Bacillus anthrax. It is primarily an infection of herbivorous animals, but occasional outbreaks occur in other species and infection in humans is seen. So epidemiology. Animals are infected by ingesting the spores. Animal infection and hence human infection are still a serious problem in Africa, Pakistan, India, Iran, Middle East, and parts of Central Asia. In endemic areas, humans are infected directly from animals or animal products. However, there is no known case of human-to-human spread. All ages may be affected, both genders can be involved. Associated diseases. Deliberate and accidental dissemination of anthrax spores is recorded, resulting in both respiratory and cutaneous form of anthrax. For this reason, Bacillus anthrax is classified as a weapon of bioterrorism, and handling is subject to regulation in many countries. Pathophysiology. Cutaneous inoculation is favored by minor trauma of pre-existing skin lesion, and pulmonary and intestinal forms result from inhalation or ingestion of spores. Systemic anthrax involves massive bacteremia and is often fatal. Causative organism is Bacillus anthracis, and this bacillus is present in large number in skin lesions and in blood in systemic infections. The major virulence factor are the binary exotoxins encoding on two virulence plasmids, PX01 and PX02. Environmental factors, presence of infected animal vector like sheep, goat, and cattle. The lesions of cutaneous anthrax follow after inoculation of endospores into the skin. The exposed skin, particularly of the face, neck, hands, and arm, is affected. Between 1 to 5 days of infection, an irritable papule develops at the site of inoculation. It may be single or multiple and is often referred as malignant pustule. The lesion is not purulent and often rarely painless. The papule changes into a pustule or a bulla on a red edematous base and rupture to form an hemorrhagic crust with surrounding edema, erythema, and several small vesicles. This is how a cutaneous anthrax looks like. This is a thick crust on the ulcer. It is also known as the scar, and multiple coalescing lesions on the arm. In some cases, particularly when face is involved, malignant edema characterized by severe swelling in duration and multiple bullae may develop. Regional lymph nodes are enlarged and tender. Constitutional symptoms may begin 3 to 4 days after the onset of pustule. Anthrax meningitis is a rare complication. Overall mortality of untreated cutaneous anthrax is 5 to 20%, but most cases are mild and self-healing in 2 to 3 weeks. Severe edema or toxemia are of poor prognostic significance, but with early and adequate antibiotic treatment, all cases are curable. Clinical variants. Anthrax may cause respiratory, oropharyngeal, or gastrointestinal disease. In respiratory type, mild primary illness is followed by a respiratory distress. In gastrointestinal type, because of ingestion of spores, symptoms include hematemesis, diarrhea, and abdominal pain. Esophageal involvement results in dysphagia and massive swelling in the neck. Differential diagnosis of cutaneous anthrax include staphylococcal infection, vaccinia, Ecthyma gangrenosum, or cat scratch disease, formerly named as para-anthrax, North American blastomycosis, and sporotrichosis. Staph and ORF may show central black hemorrhagic crust and zone of edema and erythema. History of rapid course, clinical appearance, and lack of lymphadenitis should suggest the diagnosis, which is confirmed by bacteriological examination. The disease course and prognosis. In untreated cases, malaise, high fever, toxemia, and prostration, followed by delirium, collapse, and death. Investigation. Chain of gram-positive bacilli can be seen in a smear of the lesions, but skin lesions should be cultured. Blood culture is usually positive. PCR is an important diagnostic test. Serological test is employed to detect the exotoxin components. Anthraxin skin test is available, but usually in specific laboratories. So histologically, it is characterized by cutaneous anthrax is characterized by massive subepidermal edema with subepidermal vesiculation. And numerous gram-positive bacilli are seen in the edematous stroma. Management. Treatment should be started immediately, even before the bacteriological confirmation. Oral ciprofloxacin or doxycycline is given for 60 days. Alternates are oral amoxicillin or intravenous penicillin G for 7 to 10 days. The intravenous drug users with injected form of anthrax, intravenous ciprofloxacin and clindamycin are given in combination with penicillin, flucloxacillin, and metronidazole. And wound debridement is also important. If patient is already toxic, intravenous fluid and corticosteroids are advisable. Vaccination gives some protection and should be offered to those who are exposed in course of their occupations. Prophylaxis for asymptomatic patients exposed to anthrax spores include a 6-week course of doxycycline or ciprofloxacin. A recombinant antitoxin with the name of Rexibacumab is available but not fully evaluated. Listeria. This is Listeria monocytogenes, is a gram-positive microaerophilic motile bacillus easily confused with coroniform bacteria. Survive at low temperature and grow at 4 degrees centigrade. It is a cause of listeriosis, which is an uncommon cause of skin signs and symptoms. Organism is found in water and soil and isolated from sewage, sludge, and inferior silage. It infects wild, domestic, and laboratory animals, and direct infection from cattle and sheep is a hazard to veterinary surgeons and farmers. Listeriosis is mainly a foodborne disease, and milk, cheese, and poultry are the main source of human disease. Transplacental and birth canal infection is well-recognized hazard. Infection of baby from mother milk is reported. Most adult infections are now thought to be subclinical, but mild febrile illness with GI symptoms, loin pain may occur in otherwise healthy individuals. More serious infection with meningitis or glandular fever-like illness is well known, and in immunocompromised patient, meningitis or pneumonia may dominate the picture. Cutaneous lesions are uncommon in these cases, but when present are purpuric. So neonates may develop a combination of respiratory and GI symptoms. Generalized erythema with dark red and bluish papules, especially on trunk and leg. Meningitis and septicemia may occur. Differential diagnosis is meningococcal infection with purpura. Diagnosis is made by clinical diagnosis mainly by a long incubation period, and a diagnosis is established by blood culture. Management. The first line choice of antibiotics is ampicillin, erythromycin, or tetracycline. Gentamicin may be used with ampicillin or penicillin, particularly in immunocompromised individuals as synergism occur. Infection control. Prevention of contamination of food is vital to reduce the outbreaks. Individual at high risk of infection should be informed about the cross-contamination of food through cooking of food and storage of perishable food. Erysipeloid. Erysipelotrix ruseopathy is a gram-positive rod and cause of erysipeloid. Erysipeloid is an acute, rarely chronic, rare infection confined to the skin. Human infection is contracted by direct contact, occasionally from the living animals, but more commonly from the carcasses, so that erysipeloid usually occur in slaughtermen, butchers, cook, fishermen, farmers, and veterinary surgeons. Three clinical syndromes are recognized: the localized cutaneous, which is the most common form, known as the Erysipeloid of Rosenbach, generalized cutaneous, and a systemic infection. Most human infections are localized and self-limiting. After about 3 days of inoculation, a hot, violaceous, and tender erythema develops around the inoculation site and extends centrifugally, but irregularly, with sharp and sometimes gyrate borders, which are often vesicle. Most lesions are on hands, finger, and forearms, but exposed areas may be involved, any exposed area may be involved. There may be fever and mild constitutional symptoms and arthralgia. Without treatment, healing normally takes 2 weeks without desquamation or suppuration. This is how erysipeloid would look like. Much similar to erysipelas, but erysipelas is much fierce and severe infection. Widespread skin lesions are rare and are described as violaceous with pink advancing border and central resolution. The systemic disease is uncommon, characterized by endocarditis, joint, bone, brain, and pleural involvement, congestive cardiac failure, myocardial abscess, and aortic valve perforation may follow. Blood culture is usually positive in such cases. The disease course and prognosis: uncomplicated lesions resolve spontaneously. Investigation on blood agar organisms are alpha hemolytic. And there are 2 new PCR methods which are involved in detection. Compared with erysipelas and cellulitis, erysipeloid lack the constitutional symptoms which are seen in erysipelas or cellulitis, as well as lymphanginitis. The lesions are more purplish and local joint involvement is more common. Management: most isolated skin lesions heal spontaneously in 4 weeks. Healing is facilitated by antibiotic therapy. Organisms remain sensitive to penicillin, ciprofloxacin, and erythromycin. Tetracycline are often satisfactory, but sensitivity to this antibiotic is variable. Organism is resistant to vancomycin, and for severe infection, intravenous penicillin is required. Organism may persist or on the environmental surface, though cleaning with antiseptic help with decontamination. There is fishing board, etc. Now, the Clostridium. Clostridiums are anaerobic, gram-positive, spore-forming bacilli, widely distributed in soil and in gastrointestinal tract of humans and other mammals, and is the main cause of gas gangrene. Gas gangrene or Clostridial myonecrosis. Gas gangrene is a clinical syndrome caused by infection of wounds with various species of Clostridium, alone or in combination with other anaerobic streptococci, and often with aerobic organisms such as Proteus. The gas gangrene is potentially fatal infection if unrecognized, and it may occur when wounds are contaminated with soil or water after trauma. Clostridium perfringens is isolated from skin of thigh, groin, and buttock, mainly seen in adults. Both sexes are involved, and it is associated with trauma. Pathophysiology. The alpha toxin produced by Clostridium perfringens is the hemolytic and thought to be the main virulence factor in gas gangrene. The toxin shown to affect the neutrophil migration, platelet aggregation, and also modulate host cell metabolism. Gas gangrene used to be infection of great importance in wartime, and better management of casualties has reduced its incidence enormously. It is uncommon but well-documented complication of orthopedic surgery, particularly above knee amputation in ischemic limbs. Causative organism. Mentioned already, it is Clostridium perfringens. Other Clostridium include Clostridium edematicus, septicum, and histolyticum. Clostridium species are present in soil, decaying vegetations, and human or animal GI tract. The incubation period is short in hours, that is 12 hours or 5 to 6 days. Presentation. Characterized by deep and dirty wounds in muscular region of the body that are most susceptible. However, abdominal and intrauterine infections also occur. Affected area become painful, swollen with increased serous discharge. Edema around the wound continue to spread and associated first with brownish staining and mottling, and then with bully and later with formation of black slough. Crepitation from gas in the tissue is classical but inconstant. Toxemia is severe. There is tachycardia, irritability, hypotension, prostration, which develops rapidly, and patient is pale and apprehensive but not febrile. This is how gas gangrene would look like. There is diffuse violaceous erythema, induration, and hemorrhagic blisters. The differential diagnoses include necrotizing fasciitis, melanosynergistic gangrene, and anaerobic streptococcal infection. There is high mortality when diagnosis is delayed. Diagnosis is made promptly on clinical grounds, supported by bacteriological examination of the ooze from the lesion that contains large number of gram-positive bacterial rods. Bacterial culture should take prior to antimicrobial therapy. Radiology confirms the gas in the tissue. Management. Immediate surgical debridement of all the damaged tissue is essential. Then high-dose intravenous penicillin, 10 to 20 million units is the treatment of choice. Alternates include clindamycin, metronidazole, and imipenem. But antimicrobial therapy is only adjuvant to the surgery, which is must. Role of hyperbaric oxygen remain controversial because of lack of controlled studies. Then gram-negative bacteria. So far, we were discussing different gram-positive bacteria, which were gram-positive cocci like strep and staph, then gram-positive rods like Corynebacterium, like Propionibacterium, Anthrax bacilli, and this Clostridium. Now we are going to discuss the skin infections that are caused by gram-negative bacteria. This result either from systemic spread from another site or through hematogenous dissemination or by direct inoculation. Pseudomonas species, for instance, cause skin infection by both mechanisms. The gram-negative cocci include Listeria meningitis, which is gram-negative coccus, and divided into different serotypes on the basis of capsular polysaccharides, type A, B, and C. So meningococcal infection is the first described lesion here. Listeria meningitis colonize the human respiratory tract and is transmitted by droplets from patients or healthy carriers. It may cause localized infections such as conjunctivitis and otitis media, and severe and potentially fatal disease with septicemia and often meningitis. Commonest in children aged 0 to 5 and 15 to 17 years, either gender. Neisseria meningitis, group B is the commonest infection, and group A is seen in tropical regions. The bacteremia is believed to be primary event in all forms of infection and to be the route by which the organism reaches the meninges. Early petechial skin lesion result from the presence of organisms in capillary endothelium, accompanied by disseminate intravascular coagulation with necrosis of blood vessel wall or thrombosis. Acute meningococcal septicemia with or without meningitis present as a fulminating illness. and the rash may be a very useful clue to early diagnosis. Incidence of skin rash is estimated between 40 to 90%, and it takes form of transient erythematous, morbilliform, or urticarial eruption. Our purpuric eruption is characteristic, mainly on the trunk and limb. Petechiae are small and scanty, but vary in size and number. Large purpuric lesions may also occur with extensive ecchymosis and necrotic ulceration, particularly in dependent area and under pressure sites with associated high mortality. Vasculitis may occur during acute illness. Nodules of bulli may be sparse and confined to the limbs. Arthritis and episcleritis may be associated. So these are the papillar, then the necrotic lesions of meningococcal septicemia. Clinical variants. There are a rare form of chronic meningococcemia that present with rash, low-grade fever, and arthritis, as like chronic gonococcemia. Differential diagnosis that of acute vasculitis and viral hemorrhagic fevers. Complication is skin infarction, lead to contractures and scarring. Disease course and prognosis. Infection is rapidly fatal and occur before the development of rash. Investigation confirmed by Neisseria meningitis from the blood and cerebrospinal fluid and by PCR. Management. Circulatory support and intravenous fluid. Intravenous benzyl penicillin in high doses. Alternatively, ceftriaxone and cefotaxime. Infection control by rifampicin for 2 days is recommended as prophylaxis for all family contacts. At present, vaccines are available for meningococcal infection caused by group A, C, Y, and W135, and not to group B. They may be deployed in high-risk groups. Pseudomonas aeruginosa. This is an aerobic gram-negative rod that occur only in transient member of skin flora and mainly in anogenital region, axilla and external ear, and normally it is kept under check by dominant gram-positive cocci. Pseudomonas species produce variety of different infections. It colonizes the burns, ulcers, and other moist skin lesions, and frequently contaminate bedpans, showers, sink, and urine bottles, polythene sheeting, and hands of nurses and wards in which such patients are treated. It is mainly a nosocomial pathogen. Jars of ointment may also be contaminated. Systemic infection is seen largely in immunocompromised patients who are acutely sick and receiving multiple courses of antibiotics or in the neonatal units. Pseudomonas infection are frequent in intensive therapy units, in neutropenic patients, and as cause of nosocomial pneumonia. In older children and adults, clinical infections occur mainly in patients with debilitating diseases. The gram-negative folliculitis or Ecthyma gangrenosum. On the skin surface, repeated application of bactericidal agents effective against gram-positive flora or prolonged maceration, as in syndrome of tropical immersion food, favors the establishment of Pseudomonas even in previously healthy adults. Epidemic outbreaks of follicular rash have affected users of overcrowded and heated swimming pools or jacuzzis. Pseudomonas appear to play a part in modifying and perpetuating some paronychial infection and is commonly isolated from chronic leg ulcers and chronic external otitis. Typical strains produce two pigment, a blue-green pyocyanin and a greenish yellow pyoverdin. So both stains or pigments are greenish. Presentation. The commonest local infection in infancy is periumbilical with foul-smelling bluish-green discharge and spreading erythema. Peronychial pustule may be accompanied by green discoloration of nails, involvement of lip and cheek, and followed by progressive gangrene. Inhibition of gram-positive flora or dermatophytes by maceration or antibiotic allow the development of distinctive Pseudomonas infection, also of the toe webs, which is also called as the tropical immersion foot, characterized by sharply demarcated areas of maceration and tender erosions showing green fluorescence under Wood's light. Pseudomonas can also invade superficial wounds, particularly burns and secondary septicemia may result. Fever and shock may supervene. Gram-negative folliculitis seen in swimming pools and jacuzzi users is a well-documented entity, characterized by macular, papillar, and pustular lesions which are tender. Some are urticarial and suggesting insect bite. Any part of the body that has been immersed may be affected, but the worst areas are those which are in contact with the bathing costume. In most cases, rash settles spontaneously within 7 to 10 days. So this is a greenish fluorescence which is seen under the nail due to Pseudomonas nail infection. Similarly, immersion foot syndrome when the toe webs are affected and this Ecthyma gangrenosum. In early diabetics, HIV/AIDS, and neutropenic patients, Pseudomonas is associated with serious necrotic infection of external ear known as malignant external otitis. It is also implicated in severe exacerbation of acne vulgaris. Prognosis of systemic infection is poor unless there is an early treatment. Local infection in infants and patients with debilitating illness should be regarded as potentially dangerous for systemic extension. Bacteriological confirmation of diagnosis is readily obtained by cultures from skin lesions or the blood. Significance of isolation of Pseudomonas from non-specific lesions must be carefully evaluated on clinical grounds. Management. Superficial lesions respond best if drying out is possible. 1% of acetic acid compresses or potassium permanganate soap, povidone or silver sulfadiazine cream may be of value, including topical antibiotics like polymyxin. In case of burn, extensive debridement followed by topical application of silver sulfadiazine, and some cases by ceftazidime. In septicemia or where severely compromised patients have superficial infection, the systemic therapy with antibiotics should be started. Ceftazidime, gentamicin, piperacillin, azlocillin, tobramycin, amikacin are most appropriate combination. Melioidosis. Melioidosis is caused by Burkholderia pseudomelii, which is a saprophytic environmental bacterium isolated from soil and water in low-lying rice-growing region of Far East. Melioidosis is a systemic infection result in development of skin lesions such as abscesses. Both genders are affected. Transmission in human is thought to follow. Environmental contamination of a minor injury. In human, it typically causes Glanders-like illness, which can be fatal. Clinical feature. The disease runs acute, subacute, or chronic course. Acute form is associated with fever, prostration, gastroenteritis, and pneumonia that is fatal in 2 to 4 days. Subacute cases last for 1 to many weeks Local abscess formation rapidly followed by lymphangitis, lymphadenitis, and septicemia may occur. There can be multiple abscesses subcutaneously or in muscle, lung, liver, and spleen, which often ulcerate. The chronic forms include pulmonary symptoms and metastatic abscesses in such patients with severe urticaria and is usually treated with tetracyclines. This is how the abscesses and ulcerated lesions of melioidosis would look like. The differential diagnosis are other causes of abscess like staph, nocardia, tuberculosis, or pseudohypermycosis, deep fungal infection, and mycobacterial infections. Untreated, it is fatal. Infection, the acute pneumonic and septicemic forms simulate tuberculosis, typhoid, and staphylococcal infection. Diagnosis is established by isolating organisms or by detecting a rising antibody titer. Management consists of intravenous fluids, circulatory support, plus antibiotic. And the antibiotic of choice is ceftazidime, meropenem, imipenem, or cotrimoxazole. Alternate include piperacillin and cefotaxime. Abscess requires surgical drainage once the antibiotic treatment is established. Glanders. Glanders is a specific infection of horses and donkeys by a Burkholderia melii, which can pass to humans. A rare infection, mainly confined to tropics and present as abscess and cellulitis. Humans are infected by direct contact with horses. Bacillus usually gain entry through abrasion or through conjunctiva or nasal mucous membrane, both sexes and both genders. Clinical presentation. Incubation period is 2 to 3 weeks. Prodromal illness comprises of malaise, headache, fever, and development at site of inoculation of an area of cellulitis which soon break to form irregular ulcer with offensive hemorrhagic purulent discharge. Primary site is cutaneous. If the primary site is cutaneous, regional lymphatics become swollen and tender, and dull red nodules along the course break down to form abscesses and sinuses. If nasal or oral mucous membrane is the site of inoculation, there is extensive necrosis and destruction of septum and palate. After variable interval, metastatic lesions develop, which are grouped red papules, pustule or bully, especially on joint and face, followed by ulcers that enlarge and coalesce. Deep subcutaneous abscesses with multiple sinuses may occur. Symptoms that accompany include septicemia are rigors, headache, and confusion. Dissemination lead to meningitis, pneumonia, and polyarthritis. This is how the glanders look like. This is a picturesque demonstration. DD include melioidosis, staphylococcal infection, sporotrichosis, and tuberculosis. Complication: pneumonia and septicemia. Complications include pneumonia and septicemia. The disease course and prognosis. Some cases survive for long period with intermittent bacteremia, with severe constitutional symptoms and metastatic manifestations. Others are often rapidly fatal, and in general, mortality without treatment is very high. Investigations. Diagnosis is suspected on history of contact with horses, confirmed by isolation of organism by serological test. Antibiotic is always required, and drugs that show potential promise include cotrimoxazole, ceftazidime, and imipenem. Rhinoscleroma. Rhinoscleroma is a chronic, slowly progressive, potentially fatal, infectious and mildly contagious disease caused by a bacterium which is a subspecies of Klebsiella pneumoniae, known as Klebsiella pneumoniae rhinoscleromatis or Klebsiella rhinoscleromatis, that affect upper and lower airways. The infection is originally localized in nasal fossae and invades upper respiratory tract and lacrimal apparatus, where it produces an infiltrating granuloma with marked tendency to sclerosis and subsequent obstruction. It is a condition that is difficult to cure. The disease is endemic but rare in certain countries like Central, East and West Africa, Central and South America and USA. The disease is acquired by direct or indirect contact with nasal exudate of an infected person, and more common in rural areas where social and hygiene standards are low. Infection occur in both sexes at any age, but most frequently between 20 to 40 years. The bacteria measures 3 micrometers in length. It is isolated in pairs or even short chains and is encapsulated, non-motile, gram-negative. Most investigators agree that mucopolysaccharide in capsule of bacteria is responsible for most of the damage. Clinical feature: the disease progresses through 3 overlapping stages: the exudative stage, the proliferative stage, and the fibrotic stage. The first is the exudative, catarrhal, rhinitic, or atrophic stage. Begins with symptoms of common cold, with associated headache, difficulty in breathing, fetid purulent rhinorrhea of long duration, that is weeks or months, with scabs, dryness of throat, and occasional epistaxis. There is no exudative rhinitis like rhinoscleroma, so a prolonged rhinorrhea with fetid purulent discharge should raise suspicion of the disease. Second stage is the proliferative or granulomatous stage. As the symptoms of coryza begin to subside, infiltration and obstruction of lower portion of nasal fossa occur with exuberant, friable granulation tissue, crusting and induration that later extends to pharynx and larynx. Breathing may become difficult and painful, and tracheostomy is sometimes necessary. Then the third or final stage is of fibrotic or sclerotic stage. The previously inflamed tissue is replaced by dense collagen. The healing process, spontaneous or after therapy, leads to an anatomical distortion of the nose and stenosis of the nostrils. This is involvement of nostrils in proliferative or granulomatous stage with nasal obstruction. Differential diagnoses are many, and mainly the diseases which involve the nose and central area of the face: chronic bacterial rhinosinusitis with atrophic rhinitis, mucocutaneous leishmaniasis, which is highly destructive but not proliferative or obstructive, paracoccidiomycosis, also known as blackberry stomatitis, then granulomatosis with polyangiitis, that is Wagner granulomatosis, malignant epithelial tumors and sarcomas, sarcoidosis, nasal tuberculosis, yaws, and leprosy. Complication and comorbidity. There is progressive pharyngeal and nasal scarring. Disease is seldom fatal but is disfiguring. Investigations. The radiological findings include non-specific paranasal sinus opacification, nasal turbinate atrophy, nasal mass with bone destruction. This bacteria has unique antigenic marker O2K3, and it allows immunological identification by using peroxidase, anti-peroxidase immune complex method. Serological tests are also helpful, like complement fixation test, agglutination test, intracutaneous tests are of doubtful value. Histopathology. There is a dense infiltration, consists primarily of plasma cells and 2 types of highly characteristic cells. And these are the mucolytic cells, which are large, round, vacuolated histocytes, measuring 100 to 200 micrometer in diameter, containing GIMSA or gram-positive bacilli inside the cell membrane. Inside, the bacilli are protected from the therapeutic products in the blood, and hence there is a need for long-term therapy. Russell bodies are 20 to 40 micrometer, elliptical, homogeneous, and eosinophilic bodies that are found within the cytoplasm of the plasma cells. So these are the foamy macrophages which we see in Rhinoscleroma. These are the foamy macrophages. Along with that, there are plasma cells containing the Russell bodies. Wharton starry stain shows numerous gram-negative bacteria within the macrophages. Diagnosis is based on the clinical features, characteristic histopathological features, and finding of the fresh bacilli, which is adequately identified bacteriologically and by complement fixation tests. Management. Chlamydia rhinoscleromatis is sensitive to trimethoprim sulfamethoxazole, streptomycin tetracycline, chlortetracycline, kanamycin, gentamicin, cephaloridine, and rifampicin. It is advisable to determine the antibiotic sensitivity and continue the treatment until bacteriological cure is obtained. First-line treatment is with tetracyclines, dose of 2 grams per day for 6 months, followed by 1 gram per day for similar period. In case of recurrent, cephalexin is given, ciprofloxacin 250 to 500 milligram twice daily with meticulous nasal lavage with saline. Then trimethoprim sulfamethoxazole with betamethasone 4 mg intramuscular every 3 weeks for 6 months. In this inactive fibrotic stage, surgical treatment to correct the severe structural and functional abnormalities. The nasal endoscopic techniques and carbon dioxide laser is used for the obstructive scars. Tularaemia. Francisella tularensis is a gram-negative bacteria that is responsible for tularemia, which is a zoonotic infection. It is a pleomorphic, non-motile, gram-negative cocobacillus with producing powerful endotoxin and is a facultative intracellular parasites. Wild rodents and other small animal population probably is the main reservoir of infection, and it is transmitted to humans by a tick bite. Most cases are sporadic. However, the disease is endemic in Northern Hemisphere, including USA and many parts of North and East Europe, apart from UK. Sportsmen and sportswomen and campers are mostly exposed. Any age and both sexes are involved. Clinical features. Incubation period 1 to 10 days. Clinical feature depends upon the portal of entry, which can be skin, eye, respiratory, or GI tract. Most sporadic cases are ulceroglandular, glandular, or oculoglandular. A red, painful, ulcerated nodule at the point of inoculation or tick bite is associated with enlargement and tenderness of regional lymph nodes. Systemic symptoms and toxemia may be severe. During toxemic stage, cutaneous lesions develop, which are maculopapular resembling erythema multiforme, profuse crops or nodules on the limbs. Nodular lesions resemble erythema nodosum. These are the nodular or papular lesion of tularemia. DD include tick-borne rickettsial infection, sporotrichosis, cat scratch, melioidosis, melioidosis, and Glanders. Untreated course may be prolonged. Mortality of typhoidal and pulmonary form exceed 30%, oculoglandular form 5%. Organism can be cultured from primary lesion, from lymph nodes, gastric or pharyngeal washing. Specific agglutinins appear in serum after about 10 days and increase in titer for some 4 weeks. ELISA is available in some laboratories. Management. All cases require treatment. Mainly, it is done by fluoroquinolones such as ciprofloxacin. Gentamicin is potentially useful alternate. Tetracycline such as doxycycline controls symptoms, but may not eradicate the organism, so relapses are frequent. Live attenuated vaccine against Tularaemia is available in some countries, but usually restricted to laboratory workers at risk. Pasteurella multocida. Pasteurella multocida is a gram-negative bacillus that causes hemorrhagic septicemia if host resistance is low. Most infections follow bite by cat, dog, and other animals and scratch injuries. Two main types of bacteria, Pasteurella multocida, and Pasteurella multocida septica. Most lesions are hand, arms, and lower leg. Clinical picture is influenced by extent and depth of bite. Redness and swelling around the wound may spread rapidly over wide area and break down to discharge grayish yellow hemorrhagic pus, though through one or more sinuses. If bite is deep, there may be osteomyelitis or synovitis. Lymph adenopathy is often developed. Investigation is diagnosis is done by history and confirmed by isolation of slow-growing gram-negative bacillus. The infection responds to penicillins, ampicillins, and cephalosporin, for example, cefuroxime. However, as bite wounds are often polymicrobial, it is important to follow up the patient closely. Plaque, plague. Plague is the main skin pathogen is Yersinia pestis and Yersinia enterocolitica. Yersinia pestis is a gram-negative, non-sporing, non-motile bacteria. With Giemsa, it shows characteristic bipolar stain. Plague is zoonotic infection caused by Yersinia pestis and spread by fleas found on the rats and is well recognized as a cause of large outbreak of infection both historically and in the present day. Human may be infected after contact with contaminated material. Plague was responsible for several major epidemics in Europe, Northern America, and Middle East in Middle Ages and later. The largest of these is known as the Black Death, which is thought to have killed between 1/3 or 1/2 of the population of Europe, both ages and both genders. All ages and both genders. Following inoculation of organism by a flea bite, incubation period is 3 to 4 days, but occasionally is 7 days. After the incubation period, a bullous crusted anthrax-like lesion develops, and after several days, the regional lymph nodes become swollen and painful, which is the classic bubo of bubonic plague. During bacteremic phase, a macular, erythematous, or petechial rash develop, which is sometimes frankly purpuric. That is the Black Death. The necrotic lesions that closely resemble Ecthyma gangrenosum may develop. These are the result of vasculitis and occlusion of vessels with fibrin thrombi. This is a bubonic plague lesion and necrotic lesion on the finger. Septicemic spread with severe febrile illness frequently leading to death within days. Lung involvement occur in some cases, and sputum is highly infectious. If Yersinia pestis is inhaled, it is likely to lead to pneumonic plague, which is almost invariably fatal within 3 to 4 days. In some instances, cerebral symptoms develop which are severe. Untreated plague is a fatal illness. Investigation. Even in endemic countries, sporadic cases are often misdiagnosed. Adenitis is most characteristic feature. Aspiration of bubo and direct examination of a smear and culture confirms the diagnosis. Culture of blood and sputum should be undertaken. All cases require antibiotic therapy. Streptomycin, gentamicin, doxycycline, chloramphenicol are all effective. The latter is mainly used when high tissue penetration is needed, for example, in myocarditis. So this ends today's lecture. Although it was a long lecture for today, but I wanted to finish this chapter as quickly as possible. That's why I took this long lecture, and hope this lecture was palatable for you, and hope to see you next time with next edition of my lecture on bacterial infections. Thank you all and have a good day.